This afternoon, our keynote speaker is going to challenge us to think even more broadly about building trust and collaboration and how we can shape the future of pharmacy practice together, despite how complex and sometimes broken the current healthcare system seems. It's a true privilege for us to welcome our next speaker, Susan Cantrell. Susan is the Chief Executive Officer of the Academy of Managed Care Pharmacy, or AMCP, which is a national organization representing more than 8,000 pharmacists and healthcare practitioners who are helping manage medication use for over 270 million Americans. Since stepping into this role in 2016, Susan has championed innovation in managed care pharmacy, policy, and patient access. Her career spans decades of leadership in professional associations, including previous roles as Senior Vice President for the Drug Information Association and nearly 20 years at ASHP. Her work has helped launch ASHP Advantage and establish ASHP as the only pharmacy organization which is accredited to provide CME for physicians, which is a testament to her commitment to interprofessional education and care. Susan is a pharmacist and a graduate of the University of Mississippi College of Pharmacy, and she holds a certificate in public health from the University of North Carolina Gillings School of Public Health. She brings extensive experience in medical education, healthcare regulation, nonprofit association leadership, and policy strategy. Please join me in welcoming Susan Cantrell.
Thanks so much, Ryan. I'm delighted to be here with you and really appreciate the invitation. I have the privilege of spending some time with Sarah periodically. We were both a member of a non-pharmacy organization, believe it or not, the American Society of Association Executives. And, you know, in the association world, we say there's an association for everything, you know, the welders, the funeral directors, the auctioneers, you name it, an association for everything. And the American Society is the Association Executives is the association for people who work in associations. So a little niche, but I just came from their annual meeting in LA. We missed you there, Sarah, but you had a very good reason for not being there. But really exciting times and lots of pharmacy folks there too. So it's a privilege to be with you, and I was thrilled to be invited to be here. Even though, you know, managed care in the world of pharmacy is not always the most popular kid in the class, right? So, but anyway, I love your banner outside that says something about one vision, because I think in the world of pharmacy, if there was ever a time for one vision, it is now. We need to move this profession forward in the direction that we've been heading for a couple of decades. And I think now is a golden opportunity. So we'll talk a little bit about that in a moment. But I first wanted to say I got into lovely Milwaukee yesterday afternoon. So I've been watching some of your local news channels. And I saw recently, and then again the last 2 days, the catastrophic flooding here in Wisconsin. And my heart goes out to all of you and your fellow Wisconsinites who have been affected by that. I happen to be privileged to be on the board of directors of the American Institute of the History of Pharmacy, another wonderful Wisconsin related institution housed out of the University of Wisconsin. And if you don't know about it, please take a look at it, because as John Grabenstein, the past president, always says, history informs progress. So if we look at history, we can learn a lot that will help us move it forward. But unfortunately, they were affected by the flooding as well. We got an email earlier in the week saying that they had a couple of inches of water in the offices of AIHP, where there's so much valuable archival information on our profession housed. And so the staff there and their family members have been busy trying to dry everything out and preserve all of the artifacts and the documents that exist. So my heart goes out to you. I live in North Carolina, so we're no stranger to bad weather. Thankfully, this gigantic Hurricane Erin, it looks like it's going to miss us this time, but who knows when the next one will come along. So stay strong, Wisconsin. I also have a couple of connections in Wisconsin. You wouldn't know it from hearing me talk, as Ryan said. I graduated from the University of Mississippi. I'm a native Mississippian, and I grew up in a town of about 4,000 people in rural Mississippi in the middle of the state. So my entree to pharmacy was my neighbor from a couple of blocks away, Mr. Gene Polk, owned the drugstore on the corner, and I was a clerk in his pharmacy, starting at the age of 14. And you might ask, does Mississippi not have child labor laws? Apparently not at the time when I took that job, but Mr. Polk hired me and immediately, for some reason, saw in me something that said she could be a pharmacist. And so he started talking to me about pharmacy, and I thought, I have no clue what I want to do, so that's a great idea. And he was a real authority figure in pharmacy. In fact, he was later appointed to the Board of Pharmacy in the state of Mississippi by the governor, and he was also very plugged into Ole Miss, my alma mater. So anytime the dean or the athletic director would come visit him in the pharmacy, he would make sure that I was there. And if I wasn't working that day, he would call me and say, "You need to come in, Warner Alford, he's the athletic director. He's coming by. I want him to meet you." So he stacked the deck for me to be a pharmacist, and there was no way out for me. And I could see myself at that time perhaps even owning Mr. Polk's pharmacy one day. Well, lo and behold, two of his children became pharmacists, and his son owns the pharmacy now, which is still open in my hometown, and I love to go visit when I'm there. But to the students in the room, I would say a chance meeting at an event just like this, the Mississippi Pharmacists Association meeting when I was in my last year of school, changed the trajectory of my career. And so kudos to all of the student pharmacists who are here. And if you're a P4 doing rotations and you're like, I have no idea what I'm going to do, don't worry, you'll figure it out. And if you figure it out next month, it might change in a couple of months. But what happened to me was I met a gentleman, Tom, you'll know Bernice Breland from way back when, who at the time was Associate Director of Pharmacy at the Mississippi Medical Center. And he said, "We're starting a residency program." And I said, "What is that?" And, this is a long time ago. And he said, "We're starting this residency program and we want you to come over and talk to us about the program." So I did. And I became the first pharmacy resident in the state of Mississippi at University of Mississippi Medical Center many, many years ago. And but networking opportunity just like this changed my whole perspective on my career and also on so many things about pharmacy. Now, I moved around a lot in my career, as Ryan mentioned. I've spent more than 2 decades in the association world, and advancing pharmacy policy at the national level through associations is really my passion. So, with that in mind, let me say thank you once again for having me. And if you don't mind, I'll start out by talking just a little bit about what is managed care pharmacy, because I know we all know each other, and my home state of Mississippi is not really a hotbed of managed care, no surprise there. But so I knew very little about it for years, but of course it's evolved a lot. And our members work in the trenches managing pharmacy benefits. But to start out, a little bit about our association. And I have no related financial relationships to disclose, nor do the planners in this organization. And so these are the learning objectives. We'll talk about the role of pharmacists within team-based care models, including in managed care, talk about strategies for payer-provider collaboration. And also, I'm going to touch on a few real-world examples that might spark some future opportunities that we can think through as we think about how do we continue to advance the practice, evolve the practice model, and get pharmacists paid for the services that they provide separate from the product. So that's what we'll hit upon today. But one thing that I did want to say right off the bat is that in the world of associations, we categorize associations broadly in two buckets, if you will. So on the left-hand side, you see the trade associations. And when you think of a trade association, you think of an organization like the Pharmaceutical Research and Manufacturers Organization. is one example. The National Association of Chain Drugstores. And what's different about those organizations is that their members are companies, corporations, or other organizations. And they're really focused on advancing the business interest of the member companies or the industry in which they work. So we see many examples of that. Many of these organizations are large, multi-million dollar organizations, and they're very influential at the national and often the state level. On the other side, though, is where we sit, where PSW sits, where ASHP, APHA, AMCP, and many others sit, and that is a professional society. So we don't exist as organizations to advance the business interest of any particular sector. So in our case, AMCP, we have individual members that work in health plans, that work for PBMs, that work for state Medicaid drug programs, that work for a whole host of other areas, including population health and integrated delivery networks, and also the pharmaceutical industry. So we don't advocate for the business interest of any of those employers that employ our members. We're mission driven, and that's what we focus on. Oh, there we go. So, with that in mind, we focus on our mission, and our mission is a little bit different in the world of pharmacy and might be surprising if you're not familiar with the organization. But we're all about improving the health of Americans by promoting access to high quality and cost effective medicines. And when I first came to AMCP, I've been in this role for 9 years, hard to believe. But when I first came to AMCP, we were in the midst of the run up to the 2016 presidential election. And if you remember what that was like, the cost of prescription drugs was one of the top 5 issues and probably one of the top 3 healthcare issues that all the presidential candidates were focusing on. It was a hot topic. And it's one of the things that I think drew me to this role because I realized pharmacists have such an important role to play in access and affordability. And I felt like that we could drive some policy changes and get traction on the affordability of medicines. But when you go on Capitol Hill or you talk to members of the administration within CMS or FDA, and you try to say this, you kind of get the glazed over look. So I started just trying to paraphrase it by saying, our members are trying to make sure patients get access to the medicines they need at a cost they can afford. And so that seems to sum it up a little bit better. Ryan mentioned we're an 8,000 member organization. So in the world of pharmacy associations, national pharmacy associations, certainly we're small. And I like to think that we're small and agile in some ways. But our organization has been around not quite 40 years. It was founded by 8 individuals back in 1988 who came together in a bar, as I understand it, and wrote on the back of a napkin what they thought they needed in a professional association. And those 8 people, several from your neighbor over in Minnesota, that was certainly a burgeoning area for managed care back in the day and continues to be today. But those 8 people are still alive and still engaged in the organization, I'm proud to say. So it's really been a pleasure. You contrast that to APHA, founded in the 1800s. If you go into their beautiful headquarters on Constitution Avenue, you see there are just hundreds of pictures of their past presidents on the wall. And then ASHP, 1942. So we're young by National Pharmacy Association standards. And we do all the things that individual members expect of an association: education, networking, meetings like this, and some advocacy. And I just share that we don't have state organizations, but we do have a network of regional affiliates that exists for education and networking purposes for our members at the regional level. So we do have one in the Midwest. And then, by way of background, mission driven organizations like PSW and like AMCP are always focused on their strategy, their strategic priorities for the organization. And I wanted to talk for a moment about ours because I think this is another area that unites all of pharmacy. We have four strategic priorities for the time being. We're in the process of strategic planning this year, so this could change in October when we finalize our plan. But we created this plan back in late 2020, early 2021, and we're focusing on four main areas. The first one is optimizing value and access. And that's no surprise. We're really focused on access and affordability, and paying for value is a big part of that. So, optimizing value and access through a number of mechanisms, including using biosimilars, using generics, really having an evidence-based approach to how medications are used and placed on formularies. That sort of thing is really important to our members. The second one, though, is a little bit atypical, and I have to say, were it not for the pandemic, I wonder if we would have gotten to the issue of addressing healthcare disparities. I like to think we would, but I can't say for sure because I think for many of us in healthcare, the pandemic really opened our eyes to the disparities that existed in our nation's healthcare system, not only racial and ethnic disparities, but geographical disparities when we talk about access to care, especially in rural areas like my home state of Mississippi, and also socioeconomic factors and the social determinants of health that really drive so much of healthcare now. So our board latched on to that. They said, we really need to do something about that in two ways. First off, managed care has a role to play in promoting equitable access to care, and we need to step up to the plate and do that. And then the other thing that our board said was we also need to make sure we're not part of the problem. Because when you think about how managed care works, when you're managing benefits, you can't control healthcare cost if you don't have some control over utilization. So that brings in the strategy, we call it managed care tools and strategies of utilization management. So things like prior authorization, go ahead and groan, no? Prior authorization, step therapy, some formularies. The formulary system is built on a process of improving utilization and containing cost, and all of those factors. And so we said that's all great, but if you look at that in a vacuum, sometimes you could be disadvantaging certain populations. And an example we talked about a lot was prior authorization criteria, where a patient has to see a certain specialist to get access to a specific medication. Well, if you live in Milwaukee or Madison or Chicago, that's probably not such a big barrier. If you live in McGee, Mississippi, or Morehead City, North Carolina, I can promise you that's a barrier. So, what do we do about that? And so, we were looking at it from both sides, and we continue to. The other two areas, amplifying our voice and value, we want to deliver value to our members and also really have our voice be heard through advocacy. And then the fourth is kind of inside baseball. We want to drive performance of the organization. So those are our priorities. The work that we've done on disparities, I'm probably when I finish this role, it'll be the thing that I'm the most proud of because our board really gave us a clear mandate to grab the bull by the horns and make something happen on this. So we set out to identify the areas where pockets of excellence were occurring, and one of our members was the chief pharmacy officer at SCAN Health Plan out in Southern California. And SCAN is a health plan that has a very high percentage of patients in Medicare and especially Medicare Advantage. And they also have a pretty significant homeless population and some other significant challenges. Native Americans included in their population, which we know about some of the healthcare challenges associated with the Native American community, diabetes, obesity, hypertension. And so they really had dug into their data to see where the gaps were existing and what the pharmacy department in particular could do about it. And they've done some amazing work. So we showcased places like Scan Healthcare and others that have done some great work in closing the gap there and tried to help our members learn more about that and take some lessons from that. We've also, if you are interested in reading about some of the work that's been done from a research perspective, our journal, the Journal of Managed Care and Specialty Pharmacy, is available online free to anyone. And if you search for the word disparities or equity, you'll find a huge amount of articles that have been published, especially since 2020 on this topic. Um, so we've done so much work on that we got an award for it. I just found out a couple of weeks ago, ASAE gave us a silver award for our work in addressing disparities related to medication use and access. So super excited about that. We will receive that award in a few weeks at a banquet in DC. But back to overall managed care pharmacy. And I hope you don't mind me putting this definition on here because that seems pretty fundamental. But our board created this back in 2017 and they're really proud of it. So I try to use it anytime I can. But during that time, we were talking about the fact that the work that our members, pharmacists working for health plans, pharmacists working for pharmacy benefit managers, pharmacists working for MTM organizations and other settings, the work might not be broadly understood by the public or by the healthcare community. So could we kind of put some color around that and share that? And so this is the definition that they came up with. And I just want to call out a few things. The thinking was, we're associated with the dollars and cents people, right? We're trying to save on healthcare costs. Well, yes, that's important. As some of our members say, well, if we're not going to do it, who's out there doing it? And but the evidence-based and the clinically based focus of the work sometimes doesn't get talked about. And I'll tell you, there may be some of our members in the room. They do good work. They're strong clinicians. They establish clinical programs and really focus on both patient and population health. So I think it was important to include both of those in there. It's not just about the health of the population or how much the population is spending, but we drill down to the individual patient in certain cases. But the optimizing healthcare resources, of course, is a big part of the remit of managed care pharmacy. And then Sarah thought it might be helpful to talk about what some of the specific things are that our members do. So we just dropped it into 5 big buckets. And I can't say that this is comprehensive, but when you think about the importance of managing prescription drug cost and therapy, with the fact that over 70% of office visits to physicians result in a prescription, we know the magnitude is huge in healthcare. So our members are involved in benefit design and implementation, developing various clinical programs, assessing affordability as well as value. So value assessment, kind of a hot topic right now, especially with some of the ultra expensive therapies that we talked about in the session this morning. Quality is a big area for a lot of our members, and looking at the Medicare star ratings, especially for the Medicare Part D prescription drug plans, is a major issue. And then on the commercial side, NCQA and HEDIS. So we have a number of managed care pharmacy professionals that lead that work in their organization. And then, of course, the one on the left-hand side that is no surprise there, formulary and utilization management is a very well-known function within managed care pharmacy. So why is all that important? Well, we spend a lot of money on healthcare in the US. These numbers are no surprise to any of us. They're 2023 numbers from the CMS data, where we spent almost $5 trillion in the US on healthcare, amounting to about $15,000 for each and every one of us in this room and all of our friends and family. And that amounts to, it's inching up toward 20% of our gross domestic product in the US. But on the positive side, 2023 data, we had 92% of all Americans had some sort of healthcare coverage. which we know coverage often equals access in many areas. And so that's an important number. Our organization is deeply concerned about some of the policy changes of late that might cause that number to go down even to pre-ACA levels. So we'll be keeping a watch on that for sure. And then closer to home, when we look at the pharmaceutical expenditures, these numbers have grown significantly. And I talk a lot about the expenditures of pharmaceuticals and strategies for cutting cost in the pharmaceutical space. So that quote in the yellow box there comes from work by Reuters. They update this number every year. And the first time I started using it back in 2021, it was $180,000, which is the median cost of the novel therapeutics that were approved by FDA in that given year. And we saw incremental changes, but we saw a huge jump in 2024 where it's gone all the way up to $370,000. But I also like to say that's not all bad because look what's happened in that time, just in that 3-year period in terms of innovation. Most of that is driven by cell and gene therapy. Some of it is driven by uh, uh, products that are used in very large populations. GLP-1s, can't go a day without saying it, but that's driving a lot of cost in our healthcare system too. But those things are also driving improvements in patient lifespan and patient quality of life, in overall health, perhaps helping to reduce ER visits and hospitalizations and things like that. So we can't lose sight of that. It's a balancing act. But at the same time, we have to make sure that it's sustainable. Over 7 billion prescriptions filled in 2024, a significant double-digit increase in pharmaceutical spending in 2023. And then, of course, the patient out-of-pocket cost, as we've mentioned in some previous sessions, that is a factor that is really concerning. Patients spent $98 billion in 2024 out of pocket for their expenses. So this is just kind of a snapshot of what's happened with prescription drug spending in the US over the past couple of decades. And it's caused the market shift. Probably no surprise to any of us that the vast majority of Americans right now that have a pharmacy benefit, be it in a government program or a commercial or employer-sponsored program, they're in a managed care organization. So no big surprise there. And this chart, I think, is really interesting because I have had an opportunity to visit a few other countries over the last few years just to learn about their healthcare systems with a group of health plan executives. And so we're always comparing, I went to Sweden a few years ago and, their whole system is built on primary care, but it's also, they have a single payer government funded system. But acute care is not where it should be compared to what we have in terms of access here in the US. But primary care is great. Long-term care is great, is funded by the government. So I've yet to see the perfect healthcare system, but what I do know is we might not be it because the yellow line on the top is the US. And that's a percent of spending based on the gross domestic product for the country compared to 9 other developed countries, several in Europe, Canada, and others. And then this report from the Commonwealth Fund compared those 10 countries and by 5 parameters. And you see to the far right is the US. We don't fare so well in any area except process of care. So we know these numbers. We have a lot of work to do. And so that's why I'm excited to talk to you all today because I think we are part of the answer in pharmacy. We just have to figure out how we get there. I think we have a unique opportunity at this point in time. And I think some of the factors that play into that are we keep hearing so much about the physician workforce shortage. It's a problem now, but it's becoming a bigger problem in the future where some estimates are by 2036 we'll be short by 86,000 physicians. That sounds low to me based on what we hear about patients and access to care. I love the next stat, the 12 to 1. For every one time patients in the US visit, on average, their physician, they visit their community pharmacy 12 times. So that says to me, we're accessible, we have an opportunity to make a difference here based on the connection with the patient. 60% of vaccines delivered by pharmacies during flu season. That number was much greater during the pandemic when pharmacy really stepped up in an amazing way to address the public health crisis. And I think we should all be really proud of that. And then I really like the stat on the right because I think that shows cost impact, positive cost impact that we in the pharmacy community can have. CMS estimates that over 5 years, they could save almost $30 billion out of Medicare if patients were using their medications for these chronic conditions correctly. And we have an opportunity, you have an opportunity to change that. So I just wanted to touch for a moment on, I sat into that, on that very good session that was earlier about pharmacy forecast, the great work that the AMCP Foundation has been doing for a number of years. I followed that closely, haven't read this year's report yet. But Carmen's presentation really piqued my interest, so maybe I'll read that on the plane on the way home. But we did our version at AMCP of kind of a lookout over the next few years. And we have these cartoon things because what we did was we were so excited about it that we reduced it to storyboards. And we've taken those storyboards into some of our members' organizations, to our leadership meeting and some other venues to ask people to talk through it and respond to it. And we've been working on that, incorporating it into our strategic plan. So it's called AMCP Foundation Trends in Healthcare Research. And I'll just touch on a couple of the things that we found out. We were focusing on 5 domains: health information technology, and that included AI, which I've heard a lot about at this meeting, which is exciting and scary at the same time. Therapeutics and diagnostics, payment models, the practice of pharmacy, overall the profession of pharmacy and where we're headed, and then finally public policy. So I'll touch on just 2 really quickly. This one about payment models that I think might be of interest, and some trends that we're seeing based on the research that we did, which was a little bit different methodology than the pharmacy forecast, but nevertheless, there's a lot in common there. But what we heard from the audience, again, predominantly a managed care audience, is that cash only payment is becoming much more predominant, especially when dealing with low cost generics. Now, health plans don't love that, especially in the Medicare space, because you can't capture easily those cash claims. And so if you're looking at, for example, the adherence measures in the Medicare star ratings, and you have a patient that for some of their prescriptions is paying cash, you're not capturing those claims, so it looks like the patient is non-adherent. It can affect your numbers. So that's an area that seems to be gaining traction, and what do we do about that? Cost plus models. We've heard a lot about the cost plus. Mark Cuban's cost plus model. Amazon is doing some interesting things in that area. Our audience thought that those things would increase. Value-based payments, both between payers and pharmaceutical manufacturers and payers and pharmacy networks, would increase in the future. And then, of course, the topic of pharmaceutical manufacturer direct to consumer, like the Lilly Direct program is an example of one of those, is an interesting thing to watch in the future. And then one really interesting finding that I was surprised with is the majority of the people who were participated in this survey said that they felt like rebates for more than 50% of the drug products that are negotiated will move to a point of sale within the next 5 years. which I thought was an interesting finding. And then on the future of pharmacy practice, real-time information on prior authorization status would be available 75% of the time within the next 5 years, not only to pharmacies and to prescribers, but also to patients. So that is an area of focus where so many of the health plans are moving toward automating that process and also making it more transparent. At least 25% of pharmacy jobs will have a remote or virtual component in the next 5 years, which I thought was an interesting finding as well. We talk so much about workforce across the board, and certainly we all watch the data that comes out of the University of Wisconsin every 2 years, the National Pharmacy Workforce Survey. So I think that landscape is shifting, but really some interesting findings on that as we move forward. And then investment in technology. I'll talk about that in a moment because that is really an important issue that our members have focused on quite a bit is how do we, I hesitate to use the term interoperability because I think we use that term to probably flippantly sometimes in healthcare, but really how do we make sure that we have meaningful data exchange between pharmacies and payers and also between prescribers and pharmacies? It's astounding to me that often we don't have access to the patient's diagnosis in pharmacies. I mean, that's just that defies not understanding to me. The concern about pharmacy deserts, that's something that we talk about too in managed care. Certainly, I think it's a concern for all of us. We use that statistic quite frequently when we talk about access to pharmacies. We say 90% of the American public lives within 5 miles of a pharmacy. I'm not sure that's true anymore. And that's a very concerning trend, along, of course, with workforce burnout. But I ran across recently when we think about the future and where we're headed, we in pharmacy and we in healthcare are not the only ones that are concerned about that. This report that I have on the screen, and the link is at the bottom of the slide if you're interested in taking a look at it. But this report was done by the Milken Institute. And if you're not familiar with the Milken Institute, they're headquartered in DC. They have a keen interest in healthcare and healthcare policy, mostly funded by the philanthropist Michael Milken. And I'm not sure what the connection is to pharmacy. In fact, I'm going to make it a point to try to find out what caused them to develop this report. But I was delighted to see it because it talks about expanding, it talks about advancing healthcare through its expanded access to pharmacist services. So some of the things that we've been trying to do at the national level, and they've picked up on it. It's a really good report. But I particularly liked this all-encompassing quote here that says, in a healthcare landscape where you've got rising chronic conditions and physician workforce shortages, pharmacists are well positioned to fill the gaps and address the challenges. And I think we could all agree to that. It's nice to see that validated by an external group that's not us, right? So just a few areas that I thought I would highlight, and I had a good discussion earlier today during the residency showcase. I hope it's okay for people like me to drop in on the residency showcase, but when I was walking through earlier, chit-chatting with some people, I had a really nice discussion with Allison from SSM Monroe Clinics. She's a PGY2 resident. And she was talking about her work in quality as a PGY2 resident and how the polypharmacy, she was excited to see the CMS pick up on the policy pharmacy measure and, looking ahead to when that would be incorporated into the Medicare star ratings. So we see this great model, and I think there are many, many examples, especially in the health system setting, where you have a health plan, health system partnership. And in some cases, health plans have actually hired pharmacists funded the positions to be in the clinics because they know that the pharmacist can drive appropriate medication use and lower the cost for procedures, hospitalizations, and ED visits. So there are many, many models out there like that. There are also many models out there where innovation has happened in community pharmacies that also involve partnerships with payers. And I like to talk about a few of those on the upcoming slides. I think we need more and more of those. But, I think my message here is we're past the point where we have to prove our worth, right? And when I talk to our members in managed care who are interested in this, they talk about the same thing. It's like, okay, how do we evolve that model so that we are compensating pharmacists so this work can be done to improve patient outcomes? And, I'll just mention briefly the efforts at the national level to pass legislation. I'm sure many of you are very familiar with that. Kudos, by the way, to you all in Wisconsin for getting your provider status in Wisconsin Medicaid. That's huge. And I look forward to seeing how that evolves. I think that's an amazing development. But at the national level, we have a bill before Congress introduced in the last session. We thought we might get it through, but we didn't. It was called in the 118th Congress Equitable Community Access to Pharmacist Services. So equitable apparently is not a popular word in DC this year. So the new bill that came out, which was introduced earlier this year in the House, bipartisan effort in the House, and then introduced about 2 weeks ago on the Senate side, again bipartisan. It's called Ensuring Community Access to Pharmacist Services. And I'll say we're not the lead on that at all. APHA, primarily ASHP, that they've teamed up to take the lead on this, but we're a partner in that at AMCP. We've long been on record as supporting provider status in the Social Security Act for pharmacists and also a framework to compensate pharmacists for the work they do to provide clinical services that improve outcomes and lower healthcare costs. So ECAP's bill, will it make it over the finish line in the 119th Congress? I never predict what Congress is or the administration is going to do. So we don't know, but I'll tell you that when we go on Capitol Hill, just like when APHA and others go on Capitol Hill, that's a bill that we talk about, and it would essentially codify some of the arrangements that were made during the public health crisis to expand pharmacists' purview to provide test, treat, as well as immunizations. But it's not limited to COVID, of course. It's several infectious diseases like influenza, RSV, strep throat, et cetera. So it's a step in the right direction. It's not going to solve all of our problems, but I believe it's a big step in the right direction. And in the meantime, innovators like Amina, who serves on the Pharmacy Quality Alliance board with me, she lives in Charlotte, North Carolina, owns 4 pharmacies, Avant Pharmacy, and they're strategically located in underserved areas and also near public transportation so that patients can get better access. She's done some amazing things. She was part of the group that launched a Medicare Part D program that was pharmacy based, and they also have an infusion center in their pharmacy. So Amina combines wellness with also, well, I like her philosophy. What she says is she always asks the question, why not? So why can't we, as pharmacy, do this? And she's really been innovative in her practice. And I don't know if any of you know Trip Logan or not, but Trip practices in Southeast Missouri. He's a second generation pharmacist. And I had a chance to hear him speak a couple of years ago. I've known him for quite some time, but what I didn't know about is the work that they were doing in health equity. So he's in Mississippi County, Missouri, right on the Mississippi River, very rural, agricultural area, very poor. And so what he realized was that the community needed him and his pharmacy team. And so he was able to get a number of their pharmacy technicians certified as community health workers. And now they're billing Medicare to collect and to collect social determinants of health information on their patients, but not just to collect the data and put it in their electronic health record. They're collecting the data and matching the needs of the patients with a resource for food, housing, transportation, and other areas. So he's really inspiring, and he's able to make this work from a business model perspective. So I think that's pretty exciting. And then in my neighborhood in North Carolina, Blue Cross Blue Shield of North Carolina is a nonprofit blues program. They're the largest insurer in the state of North Carolina, and they have an amazingly innovative pharmacy team there. And they have been working for several years with the major health systems in the state of North Carolina, UNC, Duke, and Wake Forest, to have the pharmacists in the clinic, the ambulatory care pharmacists, work with them on medication management, and they're compensating the health systems for that. They've expanded that now to the community. And last year, 2024, they launched something called More Than a Script. And with that, they're entering into value-based agreements with community pharmacies and their pharmacy network. And that focuses on pharmacists providing care that really goes to the full extent of their skills and training. And they're measuring, of course, all the outcomes from a standpoint of quality measures, patient outcomes, cost, et cetera. They're using, interestingly, a cloud-based electronic health record system so that they can share data back and forth between the pharmacies and the healthcare providers, or the prescribers, and the pharmacies and Blue Cross. So we'll see how that works out. But Suzanne Troutman is the VP of Pharmacy Services, and she said it's time that pharmacists are reimbursed for taking a more prominent role in helping patients and their doctors manage chronic health conditions. So we'll see how that goes, but I think it's a pretty exciting development there in my state. And then PQA, full disclosure, I sit on the board for a few more months of the Pharmacy Quality Alliance. And PQA has been doing a lot of work to try to help develop some measures that would allow pharmacies to demonstrate the value that they deliver to health plans, especially as it relates to HEDIS and Medicare Stars. So this document describes a pilot program that they did of 4 measures that related to blood pressure and A1C control. And they were working with 2 payers and 2 pharmacy networks. So interesting reading. And this is just a schematic. This is the list of medication-related measures that are included in Medicare Stars. This matters so much to health plans. I don't know if we have anyone from the health plan community in here, but you could probably tell us how many millions or billions of dollars, make the difference between 3.5 and 4.5 stars. The money is significant. And when you look at the medication use measures, which are very important, this can't be accomplished. You can't get to 4.5 or 5 stars without the work of the pharmacist. So there has to be a partnership there. And then there's some changes that are taking place this year that I think create other opportunities in the MTM space. That the addition of HIV and AIDS to the list of core chronic conditions is expected to, along with some of the other changes to MTM requirements, are expected to increase the number of Part D enrollees that are eligible for MTM services from 3.6 to 7.1 million people. So essentially doubling that number. So how do we get there? Well, I think we've made some great progress, and we should all be proud of that. But I've listed 4 things here that need to happen. You've made some headway on this in Wisconsin. A number of states are doing that. And I was sorry that I wasn't able to get here yesterday in time to hear the standard of care presentation. I'm sure that was great. I've read and heard a lot about the evolution of boards of pharmacy regulations to that standard of care model. And I think it's something that really could make a difference in our world. So, Sarah, maybe you can tell me later how that session went, but I know it was probably very interesting. expanding pharmacists' scope is a really important part of that. And, I mentioned earlier, by 2036, we have an estimated shortage of physicians by 86,000. We keep hearing about it from the medical community, but on the other hand, what is our biggest impediment to expanding scope of practice for pharmacists in the states? It's the state medical association. So that just doesn't make sense to me. But nevertheless, that's the world that we live in. And so how do we bridge that gap? Interestingly, while the organized medicine might be saying one thing, if you ask individual prescribers, which I've done, you get a very different story. You get that story like, we couldn't survive without our pharmacists. Our pharmacists make all the difference in the world. We couldn't manage medications without our pharmacists. So I think that's really important. Continuing to expand scope of practice where there are opportunities to do so. The whole issue with data exchange, we certainly need to make that a priority. We have organizations like, well, certainly at the national level, in the government side of things, the Assistant Secretary for Technology and Office of the National Coordinator, and then the Pharmacy HIT Collaborative, NCPDP, and others. So how do we leverage those organizations to help us get to the point where we've got interoperability and data sharing that gives us on all sides of the coin what we need? And then embracing value-based care and pay for performance. I think what we heard in our survey and some of the things that I've seen from others is that's likely to continue. And so when I think about what the payers need to do, they need to commit to building pharmacy programs that will incentivize and reward pharmacists for delivering care that brings value across the board to the patients, to the healthcare system, and to the payer. And then finally, aligning priorities and incentives. That's a big hurdle to get over, but I think that will be the key to how we get into the right place. And that's where we go back to the idea of the quality measures. That's an alignment of incentives right there. So I think that is potentially fertile ground for us to get to. It's a lot to do. But I also think you all have a unique opportunity with some of the changes that have happened here with Medicaid provider status, expanding roles of pharmacists within the Medicaid HMOs, the networks that you already have. CPESN is doing some amazing work. We hear from them all the time. And Troy Trigstad, if you happen to know him, is just an incredible visionary in the world of pharmacy. You've got the Wisconsin Pharmacy Quality Collaborative. And then you've got this rich legacy of pharmacy in Wisconsin. I kind of came out of the hospital world. So people like Tom Thielke and Dave Zills, who I talk to about once a month, still mentors and icons in the world of pharmacy. And that is what Wisconsin is known for. And so you have a great and unique opportunity, I believe, here in the state of Wisconsin. And then I just want to say, when we think about the world of pharmacy and how we build this trust and how we ap- capitalize on payer pharmacy collaboration, pharmacist collaboration, we have to think about who we are as a profession. And if you know Stephen Schondelmeyer, he's been on the faculty at University of Minnesota for several decades. He was the recipient this year of the Remington Medal Award at the American Pharmacists Association annual meeting, highest award in pharmacy delivered by APHA. ASHP's counterpart to that is the Harvey A.K. Whitney Award. AMCP's is something called the Stephen G. Avey Award. But he's the Remington medalist for this year. And I had a chance to hear his Remington address twice, actually, once at the APHA meeting and the second time at the USP convention. And one of his messages was about how pharmacy has stepped up over the decades. He talked about over the last 6 decades, there have been many times when pharmacy has reached an inflection point and we've stepped up in the right way. COVID pandemic was one of those, but he gave many more examples that even though I've been around for a long time, I didn't remember that. And that was inspiring to me. Again, AIHP, not to sound like a commercial, but history informs progress. So when we think about what we've been able to accomplish in the past, that's a springboard for what we can do in the future. And then another visionary this year that's been recognized in the world of pharmacy is Bill Church, who was the recipient of the Harvey A.K. Whitney Award. And I didn't have a chance to hear his lecture, but I read it later. And it was premised on something that he called the seventh generation pharmacist. And I love the concept. It apparently is a concept that exists and has for centuries in the Native American world. And when you think about the seventh generation, the premise is that you consider the impact of decisions that are made today on 7 generations in the future. And I was curious about that because I hadn't heard about it. And I read a few other different models of it where they say, think of yourself as in the middle of the 7th generation. So you think about 3.5 generations behind and 3.5 generations ahead. But whatever way you look at it, you think about what are the implications of what's happening today into the future, and then what can we learn from the past. And he also talked about building on our foundational values. And he called out 5 that really resonated with me as what we're all about in pharmacy: respect, humility, courage, honesty, and wisdom. And serving patients is at the heart of what we do in this profession, regardless of where we work. So I think we have a unique opportunity at this moment in time. And I think, going back to your banner out here, one vision, we can all work together to achieve it. So with that, I'll step aside. I'm happy to answer any questions you might have, but I want to say thank you once again for having me today.
We're gonna not take questions at the mic, so.
Thanks so much.
Okay, thank you. All right. Thank you so much, Susan. Appreciate it. Before we break here today, I just want to give a couple brief announcements for everybody. So this evening we have another Wisconsin tradition. We're chock full of traditions around here, and that's the President's Award Banquet. So this event will showcase amazing leaders in Wisconsin pharmacy and the 2025 PSW Award recipients. All the award recipients' information can be seen in the app. And on behalf of PSW, I congratulate all of our awardees. Pre-registration for the banquet was required. If you are unsure if you are registered for the banquet or not, on your name tag, you will have a little trophy on there. Please bring your badge along with you to the Baird Ballroom in the North Tower tonight for an amazing evening on the terrace with a spectacular view of the city. I hope to see you all there. We're now going to take a brief break and we'll reconvene at 3 p.m. The most important part of every convention or conference, the CE code.